The initial problem that was brought to my attention was the ED length of stay by these patients enrolled in the chest pain center, which the bottleneck in the ED just seemed to grow. On average, they can have 5 to 7 patients a day that are enrolled in the chest pain center, and those patients are typically just sitting and waiting for a test to be done. So it's really helped decrease the number of those patients that are just sitting there waiting, who aren't requiring a ton of emergency department care, but are waiting for a test to be done, and that care and focus can be redirected to those patients who are there for a medical emergency and needing that time now. The project saw a 40% reduction in length of stay in the ED from the beginning of 18 hours to now 8 hours. That was a huge change. We were able to decrease the time between labs, which was historically 4 hours and is now 3 hours, and that hour has made a huge difference. We found a ton of huge inconsistencies. So physician to physician inconsistencies, nurse to nurse inconsistencies. So we really try to take out the human factor. What can we address in the policy that is non-human factor related to decrease length of stay? By the end of the project, we saw about a 40% reduction in time spent in the ED, which is about $60,000 of cost of care that were reduced in the health system. I think the big thing that I see with these projects is they involve staff nurses. You know, we as leaders, we see, the strategic plans for the hospital, but I think bringing in that frontline staff and showing them, we're not just decreasing costs, we're actually improving care and decreasing costs and improving the patient satisfaction scores, which are all huge indicators currently for healthcare. We're relying on those things to be successful in order for us to continue with the drive of healthcare. So I think involving more people in that and frontline staff who don't see it all the time is important to kind of show why we do green belt projects and black belt and white belt. It's not just about cost reduction, but also improving the care of patients. Our project required no resources, luckily. We didn't have to buy anything, we didn't have to purchase anything. All of the education we did was internal, so using our own staff that we have here to educate and kind of revamp the protocol. So it didn't require any external or additional resources than what our current process is. Kelly Jones, who was she's a quality nurse down in the ED, was on my team, and she really took charge of a lot of the education that occurred in the emergency department, making sure that all 200 of those staff members knew the changes that were coming up. Dr. Griffin took on the physician education to make sure all the physicians were aware. We did do some flyers and things like that, but I think that, again, the teamwork and the buy-in to see the importance behind why we're doing this, the why behind it, I feel like really drove everybody to say, we need to do this, we have to do this, how can we do this? And we were able to, between our team, get it all out and roll it out.